after restoring mobility in the fibular head, I was obligated to test it in both directions and obligated to test the fibula to see if there is force transmission in the superior direction. We tested AP and we tested PA, and there's a little tiny subtle give that I'm sure the camera can't detect, but it's perceptible. And so I'm pleased with that. And we have tested cuboid, and I'm looking at midfoot now, and midfoot is actually restricted on this right side. And she did comment that the right side still felt a little bit tighter. And you'll note that this midfoot, I can rotate medially. I'm on the navicula and the cuneiforms. And so there's a little bit of yield there, okay, as it's supposed to be. On this side, no. So we have reduced ability to pronate in the midfoot, and it's probably related to the fact that there's an overpressure in abduction. This one abducts, but then there's no overpressure. So she has reduced ability of the subtalar joint to abduct, and that probably also is reflected in a reduced eversion. And if I take it into eversion or valgus, whatever you care to call it, then there is not force transmission at the end range. And on this one, I take it up to end range, and it looks like it moves a little more. I'm sure it's subtle. I'm sure we could measure it, but I can induce force transmission through it. So what I'm going to do is stop filming now, and then I'm going to treat midfoot. I'm going to distract talus. I'm then going to distract in front of the talus as well. I'll capture talus and cuneiforms and work on pronation. After that, I'll work on distracting calcaneus from the talus, and of course it's a very subtle, small amount. And then I will work on gaining abduction, which will probably then secondarily increase eversion. It's very hard to just mobilize into eversion because you hit that lateral facet in the subtalar joint. You get a distraction and the transverse plane mobility is freed up. So we'll stop filming here and we'll come back after I treat that.